Good morning, guys. This is a case that I'm going to be making a patient a lower flat plane splint. Uh, Not sure why I decided to do it myself rather than send it to the lab. I actually enjoy lab work, so I guess I just wanted to do this myself. Essentially what I did, this is a TMD patient. She had tinnitus, ringing in the ear, feeling of fullness or water in the ear. She had seen the ENT and they had confirmed that there was no pathology there. So what we did, we gave her an aqualizer. She had some immediate improvements. Um, it's kind of hard to see here because I took an open bite, but she basically is pounding on her back teeth and she's locked in her back teeth. So although she has significant overjet, which you can't see because I have the pin locked into position here, and that position is important. But if she was in MIP, you would see she has significant overjet, but she has TMD as if she was entrapped by having anterior premature coupling. So essentially, she's just locked in posteriorly. And giving her the aqualizer kind of freed her up. And before we start talking about ortho or equilibrating or anything like that, we got to get the joint happy and healthy and get the muscles happy and healthy. So we gave her an aqualizer. Her symptoms improved immediately. The aqualizer doesn't treat every TMD situation. It definitely applied here. The quick splint may have worked for her, but it might have actually been counterproductive, as the quick splint does something a little different than the aqualizer sometimes. So they're not interchangeable, but they're both tools in the toolbox. Anyways, I had her come in after the aqualizer and I captured her bite at this vertical dimension. I had her, this was through the use of a phonetic bite. You can use any variety of open verticals here. But the important point is when you do a Nightguard or an orthotic, if you take upper and lower impressions and then an MIP bite record and you send it to the lab, you're not likely to get back something that fits. And the reason is the arc of closure. So if I use this articulator here, where the patient's jaw rotates is different from person to person, which is why a face bow is helpful. One of the purposes of a face bow is to capture this rotation of axis. Keep in mind, this is not the articulator I'm talking about. I'm just using this as a point of reference. The rotation of axis is different person to person. Therefore, when you open the person's bite, if you don't have the rotation of axis on the articulator when the splint is made, you're going to end up having a bite guard and an orthotic that needs to be adjusted tremendously. What are the ways around it? Well, one is using a face bow. The other is just to capture the patient's vertical with an open bite. So you have the patient open their mandible in relation to the maxilla at a vertical that you want. I like the phonetic bite because it's a neuromuscularly derived position. You can use CR, you can use a whole host of different ways of doing this, but the whole goal here is to separate her back teeth with an orthotic so that her muscles and joints can heal. So I captured her here and mounted the case accordingly, and we have this semi-adjustable articulator that is, I say semi-adjustable, this is not a semi-adjustable. I forget the name of this, but essentially this is more of just a mounting articulator and not actually something that replicates the nathologic system like a semi-adjustable articulator would. With that said, I don't need it because I captured her at this vertical. This is her vertical that I captured from her, so I don't need a face bow here, which is the beauty of this technique. Now what I'm going to do, so I did a suck down, as we can see here. I set the pin there, so I used the bite, trimmed the bite back, mounted it, set the pin, took the bite away, did the suck down in the BioStar, and here I am. Now if I gave her this Essex, would she get better? Maybe, because we're opening her to some degree. We're possibly removing any sort of interferences or entrapments. But the topography of the Essex is rather irregular. And for TMD patients, flatter is typically better because most of the people have interferences. So adding something that has a high degree of interferences is probably counterproductive. So here's what I'm going to do. In the lab up here, we have this box. So this is ortho resin. What I'm going to do here is I'm going to mix these two together and I'm going to add it to here. So this is a powder and liquid resin that self-cures. And I'm gonna basically try to create a nice flat plane appliance. And while it's setting, I'm gonna do this, tap, tap, tap. And I'm gonna get it to set while the pin is closed. Once it's set, then I'm gonna put articulating paper, tap, tap, tap. And wherever the occlusion is here, I'm gonna adjust around it so it's flat. And what I'll be left with is a flat plane appliance at that vertical. And in this case, a lower. I find patients tolerate the lower better, especially if we're going to ask them to wear it during the day. So I will see you on the other side of mixing the ortho resin or the splint resin. I am going to roughen this a little bit, and I'll put some monomer on this before I put it on so that it sticks well. I'll see you when I do that.